Hello everyone and welcome back. Thank you for joining the Fielding School of Public Health's Continuing the Conversation webinar. I'm Shweta Saraswat, Communications Officer at the Fielding School. Although many people in the United States will gain health insurance as a result of the Affordable Care Act, undocumented immigrants are one group that will not benefit much from the new law. This is because the 11 million undocumented immigrants residing in the U.S., who are most often young, working adults in good health, are excluded from participation in the new insurance marketplaces and state Medicaid expansions. Dr. Stephen Wallace will examine the health status and healthcare use of undocumented immigrants and suggest policy alternatives that could improve their access to needed healthcare. If you have a question during or after the lecture, please type it in the field at the bottom of the chat window, and you can see the chat window in the bottom left-hand corner of your screen. Okay, Dr. Wallace, let's get started.
Great, thank you. I want to thank everybody who's joined us today, and thought that I'd start with a little bit of background about how I got interested in this topic before I actually get into the data. My own interest in the topic comes actually from my own family background. My mother's great-grandfather came from Germany in the 1860s and settled in the Sacramento area of California. So I can trace my heritage back to immigrants in California 4 generations ago. And then my father's family came to the United States from the Poland-Russia area in the early 1920s and actually settled in Boyle Heights, which was an immigrant community even back in that day and continues to be an immigrant community today, and we've done some work in that community. I think maybe part of my motivation is after he arrived in the 1920s, the United States basically closed the borders to immigration from Eastern and Southern Europe as well as all immigration from Asia. Because people like my family were seen as undesirable, and we see some of that politics again today. So this is a topic that has lots of emotion, lots of opinion, and doesn't have a lot of data. So I'm here today to provide some data and some solid facts that we can talk about the issues of undocumented population, insurance, and what's happening with the Affordable Care Act. So with that in mind, I want to start by acknowledging that some of this work has been funded by the Commonwealth Fund and has included a list of collaborators here at the UCLA Center for Health Policy Research, including in alphabetical order, the late E. Richard Brown, Natty Peratt, Mike Rodriguez, Tabashir Nabari, and Jackie Torres. So I want to thank them for their partnership. Last fall, we released a report in collaboration with the Commonwealth Fund, and a lot of the data and information that I'm going to be presenting today can be found in that publication. It is on both our website, which you see the URL above, as well as the Commonwealth Fund's website. So if you put undocumented and uninsured into either of our websites, you can pull down the entire report. So if there's particular information you're interested in, it's all there. So for today, what I want to do is cover 3 specific issues and have time for some Q&A as well. First, I want to talk about what the current status is for undocumented immigrants around specifically health insurance and access to care. I'll then briefly summarize likely changes that the Affordable Care Act is going to bring to the health insurance landscape and how that's going to affect undocumented immigrants in the immediate and then potentially the long term. And what I don't have on here is I do like to talk about solutions, and so a couple potential directions to go. So let's start off with a brief profile of who undocumented immigrants are in California. So this information is based on the California Health Interview Survey. We ask a series of questions of 40 to 50,000 households statewide every 2 years, and we actually don't ask undocumented status, but we ask enough questions that we can impute undocumented status to those in the survey. And in that data, in the 2009 survey, when we weight it up, we come up to about 1.8 million persons in California are living here without legal status. Another 2.4 million are immigrants who are lawful permanent residents. They have a green card or some other type of long-term residence document. And then almost 4 million are immigrants who are naturalized citizens. And what you can see from on this chart is not only the numbers, but also how it distributes out by status from where they come from. So the largest group of undocumented in California by far are from Mexico, but there are also some from, a sizable number from Latin America, a sizable number from Asia and Pacific Islands, and a relatively small number from other countries including Canada and some of the European countries. So we're talking about a little under 2 million, and this is non-elderly adults. Children, the numbers are much smaller, and we'll talk about the families of these adults towards the end of this talk. But this is the group that is the predominant group of undocumented immigrants in California and nationally. The other part that I should mention is California accounts for something around 25% of all undocumented immigrants in the country. So I'm focusing just on California, but California really leads the nation in what the impacts are on undocumented workers. So I said undocumented workers, and I say that advisedly because, as you see here, most undocumented immigrants are in the labor market. The number one reason that undocumented immigrants come to the United States is for work. 95% of undocumented men are actually in the labor force, and almost all of them are actually employed. The picture here is from an LA Times article a couple years ago of car wash employees. That's a sector of the economy that is largely undocumented workers. Other sectors including construction, agriculture, some of the service industries such as dishwashers, busboys, gardeners are all heavily dependent in California on undocumented labor force. And as a result, most families of undocumented people have a full-time worker in them. Now the occupations that I mentioned are important because these are also occupations that have high rates of injury and very low rates of benefits. So very few of these industries offer their employees health insurance. Almost as important as health insurance, many of them also do not offer sick leave. So you not only have to pay for your own health care, but you sort of pay twice because you also lose a day's wages if you seek health care. So it's a high risk occupations for injuries, low rates of health insurance, low rates of other benefits. The second reason after work that people come to the United States as immigrants is family reunification, and once again, typically that's to a family with workers. So when I'm talking about undocumented immigrants, I am talking about working families. Okay. So the types of occupations that undocumented workers are in are low-waged, and they're often supporting families. What this slide shows is that over half of undocumented immigrants live in families where the total income for that family is below the poverty level. I don't know how many of you heard my talk about a year ago about the federal poverty level, but in California in particular, when you talk about poverty, you're really talking about extreme low incomes. For a single individual today, the poverty level is $11,670. So imagine trying to pay all of your bills, your rent, your transportation to work, your food for just over $11,000. And over half of undocumented immigrants are doing that. I think what's even more of a challenge is many of them have families back in their home country and are squeezing pennies out of that $11,000 to send money home as well. So we're talking about individuals who are living in dilapidated, overcrowded housing, have poor diets. The picture on this slide is of people receiving food at a food bank, which is one way to stretch the food dollar a little further. And that then provides them with very few resources for seeking needed medical care. So there are both a series of health risks that are involved in the low wage, low benefit jobs that they carry, as well as broader risks to your health. So in a low benefit occupation, undocumented immigrants, that's the black bar on the far right, are also the least likely group to have any health insurance. So in California, 51% report having no health insurance. That compares to 16.7% for US born, and actually a very similar rate for naturalized citizen. And I apologize, for some reason the number didn't print out on the LPR, the legal permanent resident, but those numbers are in between. So clearly being undocumented puts you at a high risk for having no health insurance. A question that does come up sometime is, well, what about the other half? What do they have? And if a person is working for an employer that offers employer-provided insurance, undocumented immigrants do get employer-provided insurance. There is a program called Emergency Medicaid, which provides coverage for people who have an emergency health problem and life or limb is at risk. And so if they've gone to the hospital with a life-threatening emergency, then they would report that they'd had Medi-Cal. In California, Medi-Cal also covers labor and delivery. So a woman who's had a child recently will report that she's had Medi-Cal. So, and then finally, some counties such as Los Angeles, San Francisco offer a county health plan, an ability to pay plan, which provides some level of services through county facilities for anybody who does not qualify for Medi-Cal and is low income. So none of those programs, except for employer-provided insurance, really can be considered comprehensive insurance. So even though it suggests that in California 49% of undocumented immigrants have some type of insurance, that's really a small fraction of that that have what any person would consider comprehensive insurance, where you are comfortable accessing the health care when you need it and are able to pay a modest amount. So it should be no surprise that as a result of low incomes and low levels of health insurance, undocumented immigrants are the most likely to have no usual source of care. So when they're asked where do they normally go when they need health care, there's not a particular place they go. This has led in part, and you can see the numbers once again for both residents with a green card as well as undocumented residents. It's about a third do not have a usual source of care. The picture in this particular slide is from last fall, when there was a free healthcare day at LA Memorial Sports Arena. People may have remembered seeing this in the news. And over 4 days, they provided free care to anybody who showed up. And there were literally tens of thousands of people that lined up starting at 5 in the morning to come and get a free dental exam or a free health exam. And so those are people who don't have a usual source of care, who don't have health insurance. And so they end up with episodic care. They end up with waiting until the last minute when they have a health problem and it becomes more severe, and are generally less able to deal with health problems. So the next series of slides I also want to note are adjusted for age and sex. So I say that because immigrants tend to be younger. I didn't show you a standard demographic slide, but in the 18 to 64 year age range, immigrants tend to be 18 to 40, and the US born population tends to be more heavily in the older age groups. So in some instances, when you're talking about healthcare use, healthcare needs, an older population is going to have higher use and higher needs simply because of the higher rates of illnesses that are possible. So we are actually comparing apples to apples and oranges to oranges when we're looking across immigration status in the rest of the slides, because they take that into account. So if all these populations had the same proportion of young people and middle-aged people, these would be the rates that they had. So these are truly representing the barriers due to citizenship status. So no usual source of care is a huge problem for this population. And so once again, it should be no surprise that with low rates of health insurance and without a good connection to a regular source of care, you see undocumented immigrants with the lowest rates of having seen a doctor in the past year. So this is where standardizing the populations by age and sex are very important. So these are really similar types of people. Now the one caveat here is that there is relatively good data that suggests that immigrants, when they first arrive in the United States, are healthier than their US-born counterparts. So some of this may be explainable due to a healthier population. On the other hand, I just discussed a couple slides ago that these are people who are more likely to be in occupations where there are higher rates of injuries. You saw the car wash person. Those people are more likely to be exposed to both respiratory problems because of the moist atmosphere, as well as a lot of skin problems. Agriculture, which is predominantly undocumented immigrants in California, has the highest rates of injury of any occupation, along with a lot of chemical exposures, abrasions, skin exposures, and so forth. So the fact that they arrive healthier doesn't mean that they do not have medical needs. But they're not seeing the doctor. So 15% of US-born people do not see the doctor in the period of a year, and if they're undocumented, it's twice that rate. The one piece that does surprise most people is this data point, which shows that undocumented immigrants are the least likely to visit an emergency department in the past year. If you think through why people might visit the emergency department, it actually becomes clearer. So if you don't have a usual source of care and you get sick, you might say, well, I'll just go to the emergency room because I don't have a doctor. But immigrants know that emergency rooms are very expensive places to go. They do not frequently have insurance to cover it. And so rather than face a bill for hundreds or even thousands of dollars for their illness, they're more likely to go to other sources, and we'll discuss some of those other sources. So when they're going to an emergency room, it is more typically for an emergency. And so you can see that the rate of emergency department use is about 50% lower among undocumented immigrants than it is above US-born persons, and is lower than naturalized citizens and legal permanent residents, both of whom do qualify for some types of health insurance. So where this becomes a problem is when you are a facility such as pictured here, Harbor UCLA, County USC, you're located in areas that have high proportions of immigrant populations. And so those are areas where undocumented immigrants are also likely to settle. So these hospitals will experience as a particular hospital a large volume of uncompensated care in the emergency room, not because undocumented immigrants or uninsured immigrants are overusing emergency rooms. According to this data, they're using it less than average, but simply because they're not evenly spread across the state. They're more likely to be in immigrant communities, so the hospitals that serve those communities are more likely to see them. So it doesn't deny the fact that some hospitals are challenged with the costs of care for uninsured immigrants through their emergency rooms, but it's not the immigrants' fault. The immigrants are actually less likely to use emergency rooms than average. It's the concentration problem and the problem that they do not have health insurance. So to sum this up a bit, immigrants are generally healthier than the native population, and so on average have less need of acute medical care. They tend to be healthier because they arrive healthier. They tend to have healthier behaviors in terms of diet, smoking, alcohol consumption. People who are recent immigrants, if they become very sick, often return to their homeland. And so we talk about this group as having a high level of health capital. They're in generally good health when they first arrive, and this is actually a resource that they bring with them. That doesn't, however, negate the fact that they need adequate access to health care. and they need that for preventive health care so that they can maintain their level of health capital so that they can stay healthy. And in public health, we're really interested in keeping people healthy, not waiting until they're sick. And so access to appropriate primary care is an important part of that. And then the basically occupational coverage, the occupational injury risks are higher than average. So they need screening, prevention, and occupational health to help keep them healthy. And then finally, because they are in low-wage, low-benefit occupations primarily, they face financial barriers to being able to get the health care that they need. Okay, so I think everybody's heard a lot about the Affordable Care Act. There's a lot in the news. I'll actually start with the second bullet, the individual mandate, which says that every person must have health insurance or they pay a fine, started January 1 of this year. And the fine starts out fairly low this year. It will be going up. But what's been in the news is that there are subsidies for persons with low incomes. So if a person's income is between 100 and 400% of the federal poverty level, they can qualify for subsidy if they go through in California, Covered California, which is a state-organized exchange. In states that have not set up their own exchanges, there's a federal exchange, and those have all very much been in the news. And when you hear in the news about how many people have signed up for Obamacare, really what we're looking at primarily are people who've gone through the exchanges. The second component of that is that employers are being given an incentive to provide health insurance, and that's the first bullet, which can also be called player pay. So if they don't offer health insurance to their employees, they have to pay a fine or a fee, which then is supposed to recycle to help subsidize individual insurance policies. That's been delayed because of the complexities of the system, but that will be coming into force. And the smallest employers, those with under 50 workers, are exempt from the fine, from the pay part, but they will actually receive subsidies from the federal government if they purchase insurance for their employees. Now that's particularly important for undocumented workers because they're more likely to work for small employers. And so the more that small employers can be encouraged to provide insurance for their workers, if they're working and the employer provides the insurance, they are more likely to actually be covered in that way. The third bullet down has also received a lot of attention in the media, is the expansion of Medicaid, and that in California and in about half the states in the country increases coverage to 138% of the federal poverty level. So in many states, they only covered people with very low incomes, much below the federal poverty level. So the federal government is helping states to increase the incomes at which you can qualify for Medicaid, which is Medi-Cal in California. And particularly important for immigrants is that it will also now, in those states that do an expansion, cover basically everybody with low incomes. So previously you had to be in a family with children or be a child to qualify for Medicaid. Now you can be a single working adult, and if your family is low income, as many people in many of these industries are that we've been talking about, they'll be qualified for Medicaid. Because of a Supreme Court decision that it took what was supposed to be required for all states and made it optional by state, some of the large states like California, New York, Illinois are doing the expansion. Some large states with large immigrant populations like Texas and Florida are not. And so that creates another level of complexity that we'll talk about in a minute. And then the fourth part of healthcare reform that's important for immigrants, in particular undocumented immigrants, is that there was additional money to expand the capacity of community health centers, not necessarily the day-to-day funding, but the actual infrastructure was paid to expand. And then a rather arcane payment system called disproportionate share hospital, or DSH DISH payments, were reduced, and I'll talk about that in a minute. So these are some of the key elements of healthcare reform that will have implications for undocumented immigrants. Here's some of the issues I want to talk about in terms of how it impacts them. The first question is, if we have somewhere around 11 million undocumented immigrants in the country, so the estimates are between 11 and 12 million, what does healthcare reform do specifically for them? And what does it do for undocumented immigrants with mixed status families? I'll talk about that. A mixed status family is where typically children are born in the U.S. and are U.S. citizens. Parents and maybe some of the other children in the family might be documented or undocumented immigrants, and what's happening to them. Question is, how will employers of undocumented immigrants respond to the incentives to provide insurance? And so that's the immigrant population as a whole. There's a subgroup of undocumented immigrants, the Deferred Action group, which used to be called the DREAM Act youth and is now DACA. We'll talk briefly about them. There's been off and on discussion. This U.S. Senate passed a bill on immigration reform, and there was some discussion of what was happening with that, and I will talk a little bit about that, and then the impact on the safety net. So there's actually quite a lot of implications in here. So here's the easy part. What does the Affordable Care Act say about undocumented immigrants? And so I just cut and pasted this out of the actual law, and I'll just read it quickly. I know you're not supposed to read PowerPoints, but this one says, no federal payments for individuals not lawfully present. So those are the undocumented. And this is a subsection that basically says nothing in the subtitle or the amendments made by this subtitle allows federal payments, credits, or cost-sharing reductions for individuals who are not lawfully present in the United States. So that basically says that if you're undocumented, anything that ACA does to spend money on improving access to health care through payments, credits, or cost sharing for individuals, you don't qualify for. So it exempts undocumented immigrants from the fines if they have no health insurance. It also bars undocumented immigrants from any Medicaid expansion, from any subsidies in the exchanges, and actually even bars undocumented immigrants from going and paying full price in the exchanges. Since the exchanges were set up specifically under this law, undocumented immigrants are not allowed to buy policies which should be more affordable through the exchange. So they're basically, there's no change in their status. So what does this leave with undocumented immigrants with? This leaves them with what they had before. So as I mentioned earlier, there is emergency Medicaid, or Medi-Cal in California, which pays for life-threatening conditions in the hospital, but only during the time when they're life-threatening. When they're stabilized and you're discharged, if you need rehab, if you need medications, if you need any other type of services to complete your recovery, that's not covered. It's only the emergency phase. In California and some states, other states, it does cover prenatal care and then labor and delivery. The labor and delivery is the only part that's required. The prenatal care is at a state option. In addition, there are some public health services that are covered that are independent of a person's immigration status. So immunizations, typically family planning, are for anybody who is resident in the United States independent of their immigration status. But we're talking little slices and pieces here and there. And then federally qualified health centers, community clinics, are seen as the primary care provider of last resort. They all have federal grants to provide services to people based on their ability to pay, which is not part of the ACA, and they are seen as the source that undocumented immigrants and the rest of people who will not be covered by ACA. So when the ACA is fully implemented, it's anticipated there'll be at least 23 million people still without health insurance. And so actually the majority of them will be U.S. citizens and lawfully present immigrants. And so the community health center system is seen as the residual source of care for these individuals. The final area that I also mentioned earlier is some California counties have a residual program that includes the undocumented, but once again, those individuals often face long lines and delays in care because of the funding in those systems. So the situation of the undocumented is not improving under the ACA, and it's possible that it will even get worse. So what are some of the particularly vulnerable groups among the undocumented as we move forward for access to health care? One are mixed status families. So it was estimated 5 years ago that there is 8.8 million mixed status families. That number has probably gone up. So this is one or more documented adults with undocumented or other children. And what this shows is that there is a large number that have US-born children and undocumented adults. What happens in those families is the children, because they're born in the US, are automatically US citizens. They are automatically eligible for Medi-Cal if they're low income. They would be eligible for insurance subsidies if families are low income, but not low enough to qualify for Medicaid. They're eligible for all of the things, food stamps, that any US citizen is eligible for. Because they have an undocumented parent, sometimes an undocumented sibling, the concern by the families is that by going and claiming public benefits that they are legally entitled to, they could either A, put themselves at risk for discovery and deportation, and so the last thing a parent wants to do is to be sent out of the country away from their US citizen child because they were applying for food stamps. There's also a fear that if they apply for Medi-Cal for their children, that will be used against them if the parents then later apply to regularize their status. So there is specific federal guidance that says that non-cash benefits, such as health insurance, are not considered a public charge, which can be used against immigrants if they apply to regularize their status. But there's a concern, a worry in immigrant communities that even if the federal government says it won't be held against them, that somehow it might be. So there's a chilling effect in mixed status families for going and claiming the benefits that the US-born citizen children have every right to, just as any other US-born child has the rights. And then finally, there's some suggestion that families with mixed status children, so some children are US-born and some are undocumented, the families feel very strange saying, well, my 2-year-old child can go to the doctor, but my 4-year-old child can't. And so there's some concern within families around equity issues. And so signing some children up for health insurance benefits that all of the children are now eligible for can also in some families serve as a deterrent for signing up. So mixed status families are a large and growing concern, and the continued exclusion of undocumented immigrants from any coverage under the Affordable Care Act continues and reinforces the chilling effect of signing children up who are otherwise eligible. So after healthcare reform is fully implemented in California, the estimate is that 90% of people will have insurance. Of the 10% who won't, you can see the circled area here. Let me see if I can do this fancy little finger. There we go. So that group, the uninsured and not eligible, is primarily undocumented immigrants. And so that is, as you can see, so 3 of the 10%. So somewhere between a quarter and a third of the remaining uninsured will be undocumented, but that means that 2/3 will be documented persons who are uninsured. So it's an important group, but in terms of the total California population is relatively small. What about the deferred action for childhood arrivals? So this is a group that there's been legislation to provide a path to citizenship for. These are children who were brought by their parents, who were born outside the United States, were brought in without authorization, and have typically gone to schools, have graduated from high school, may speak no language other than English, but are still under threat of deportation because they don't have the proper documentation. So President Obama, after the DREAM Act did not make it through Congress, administratively provided them deferred action, which means they will not be deported, and are allowed to apply for a Social Security card. The specific requirements, it's a little arcane. I put them on the slide just so the idea was as they were born after 1981, so they're young adults, and came to the U.S. before they were age 16, so they were brought by their parents. They've been here for a number of years, and it's estimated there are about 300,000 who are eligible in California, a little half of whom have signed up in the last year to receive this status. So if they're in the U.S., the Immigration Service knows they're here, they acknowledge they're here, they've signed up. Normally, they would then be eligible for public benefits because the federal government has said, well, you don't have the proper documentation, but we're not going to deport you. Because of the politics around undocumented immigration, the administration, which extended the deferred action, said this deferred action does not make them eligible for any federal benefits. So this is sort of a carve-out. Normally they would have been eligible for some benefits, but they're explicitly, as with under the Affordable Care Act, excluded from federal benefits. So that includes federal funding for subsidies to purchase health insurance through the exchange. It includes federal funding for Medi-Cal, even if they're low income, food stamps, sort of all of the federally funded benefits. Now in California and a couple other states, the state at the state level decided to include DACA youth as being eligible for Medi-Cal, but it does that without any federal subsidies. So normally the federal government in California split the cost of providing Medi-Cal. For this group of young adults who have grown up in the state is footing all of the bill because they are not eligible for federal funding. If you're interested in more information about DACA youth in California, the UC Berkeley Labor Center and UCLA Center for Health Policy Research have an analysis of some focus groups with these youth and an analysis of the California Health Interview Survey data for these youth, which is coming out later this month. So stay tuned for that. So where are immigrants getting care, and what does this mean for those who have no health insurance? So if you remember earlier, I said that undocumented immigrants and actually LPRs are the least likely to have a usual source of care. When they do have a usual source of care, when there is a place where they normally go, a clinic is the usual source of care for almost 3/4 of undocumented immigrants. So the sector that policymakers were thinking would be the residual, would pick up the slack for people who no longer have health insurance, are clearly already the group already the source of care for undocumented immigrants. What's interesting is if you look at U.S.-born adults 18 to 64, only a quarter of them use a clinic for a usual source of care, and that's because most of them have private health insurance and see private doctors, but that's still almost a quarter of U.S.-born non-elderly adults are using a clinic as their usual source of care. So it's a very important sector for access to care. It's critical for the undocumented, but it's actually important across the categories of immigration status. Among the U.S.-born, it's heavily people who have Medi-Cal, low income, or are in medically underserved areas, and so clinics are an important source there. What will likely happen as healthcare reform kicks in and a significant number of new low-income adults have Medi-Cal or Medicaid nationally is that they will be turning to community clinics for their usual source of care more often and will increase demand on the services there. They'll bring funding with them because they're newly insured, but the group that's the most dependent on community clinics are undocumented, who will have no chance to have increased sense of reimbursement. So one concern, and it's a concern that will have to be monitored to see if this plays out or not, is that as the proportion of clients at clinics is increasingly insured, if they're not able to increase their capacity sufficiently to meet the demand, that there might be competition between patients bringing in insurance dollars and patients who don't have insurance who are going to be disproportionately the undocumented. So it could put pressure on access to care even in the community clinic sector for undocumented immigrants because they'll remain uninsured. Okay, here's the arcane part that I was talking about. Hopefully this will be clear. You can ask in Q&A if it's not. So hospitals currently get $11.5 billion in extra federal funding to help compensate for the large number of uninsured patients that some hospitals serve, as well as large numbers of Medicaid patients that they serve, because Medicaid is usually a low-cost, low reimbursement payer for hospital cares. So if you're Harbor UCLA, if you're County USC, if you're a private hospital in an immigrant community, chances are that you have an above average number of patients that can't pay for your care or who are using Medicaid, which doesn't pay necessarily the full cost of that care. That gets distributed out to states. Each state then comes up with a formula to distribute it down to the hospitals that are the most needy. So in passing the Affordable Care Act, Congress said, well, we're going to be covering a huge proportion of those people who are uninsured, so hospitals should not need as much DSH funding, the disproportionate share funding. And so in the legislation, which is shown in the little bar below, it's already legislated that the amount of money for this extra compensation will be decreasing each year as more and more people are covered through the Affordable Care Act. So in 2019 and 5 years from now, it's expected to be $5.6 billion less than it would be otherwise. So that's going to hit public hospitals and charity hospitals particularly hard. One study found that 30% of the uncompensated care provided by public hospitals was reimbursed or was offset by DSH funding. So the big question here is, will public hospitals and safety net hospitals be able to generate enough new funding through Medicaid, which, as I already said, is actually a low reimbursement payer, and newly privately paid patients that get their insurance through the exchanges? Or will they actually be squeezed even more? And then when you're thinking of which hospitals would be the most particularly impacted, there'll be hospitals that are in immigrant communities with large proportions of undocumented residents. So they will see a lower than average increase in their compensated patients, but may face an average decrease in their DISH payments, which means that hospitals that have large immigrant and undocumented caseloads may see a larger decline than they can manage for providing that care. Now, a lot of those hospitals also have community clinics. Some of the public hospitals, such as in LA County, also have arrangements with nonprofit community clinics to help them pay for uncompensated care. So there's the potential here for what sounds logical, which is you're giving more money through one mechanism so you can decrease the amount of money you're giving through another. But because that only works on average, where you've got uneven burdens of care, which will be in immigrant communities, you may actually see a decline in access to care in both hospital specialist care as well as potentially a trickle down into the community clinics as the total pot of resources for that population decreases. This is just a simple graph that shows you a little more dramatically how the money is supposed to decline. It goes down from in 2019 from inflation adjusted about $13 billion down to under 8. So that's a huge decrease in what would be projected. So we have some insights into what might happen from the experience in Massachusetts. As you may recall, Obamacare was actually loosely modeled after what Governor Romney signed into law in Massachusetts when he was there. And there was a large increase in health insurance, but actually there was a relatively steady state demand on the safety net providers. And that's because safety net providers were convenient. So once again, if you think of immigrant communities and undocumented immigrants in those immigrant communities, the care they're going to seek is going to continue to be from safety net providers because it's at hand. Safety net providers tend to provide affordable care. And in Massachusetts, the immigrant community wasn't as large, so ability to speak patients' primary language was not as big of an issue. In California and with undocumented immigrants who were born abroad, that will be a significant issue. And this shows you where the different groups got their health insurance. So once again, in Massachusetts, the total uninsurance rate dropped to under 5%. But among those who went to safety net clinics and had low incomes, about 10% were still uninsured. And so this is a potential for California and the rest of the country where the policy goal is to have everybody with health insurance so that you don't have to worry about the uninsured population. But the reality is there will be a significant residually uninsured population, and they will be impacting the care provided at clinics and hospitals. Now this becomes even more of a problem outside of California. So as I mentioned earlier, states like Texas and Florida are not expanding their Medicaid programs. And so they will have a lower infusion of new money into their healthcare system at the same time that they have reductions in DISH payments for hospitals. And so there will be an even greater gap between the residual need and the resources available for the safety net. So that uninsured number for safety net providers in states that do not do Medicaid expansion is likely to be several times higher and will put even further stress on those providers, which then may in turn have an impact on the ability of the undocumented to get care when they need it and where they need it. So once again, some of the challenges to Affordable Care Act implementation that impacts individuals in California. There are language barriers to those who qualify. There are no undocumented immigrants who qualify, but other people in their communities who, if they sign up, would bring more resources to the same sets of providers. So far in California, we've seen a below average sign-up rate among all Latinos, and that's not just because undocumented aren't eligible, but there have been needs to be additional outreach into Latino communities, which would help the safety net in those communities, which would in turn help access to care for the undocumented. Mixed status families need special outreach so that it's clear that their children, clear to them that their children are eligible. California Healthcare Exchange has information in Spanish that tries to assure people about this, but there needs to be additional outreach into communities to make sure that all of the eligible children are enrolled to the extent possible. And then we need to be very careful to monitor the capacity of the safety net as the mix of payers and the mix of patients changes as healthcare reform rolls out. So, quick summary, currently undocumented immigrants have very low access to care that will not increase under the ACA and in fact may decrease. The ACA specifically excludes undocumented immigrants, and the changes that are occurring, some expansion to community clinics, which could help, but there's also a decrease in the funding for the safety net through other sources that may reduce that. And then the final result is a possible reduction in access, which would be an unfortunate unintended consequence of healthcare reform for that group of individuals without health insurance. So what can we do specifically for the undocumented? I'll just spend 2 minutes briefly summarizing this. It's spelled out more in our report, and we can deal with questions on that. One is to simply do what some countries have done, what Vermont is doing, and move to a universal single payer system where everybody who's living in the state is covered. So you don't have to prove citizenship or permanent residence. If you are living and working in a state, you get a card that gets you access. That's the simplest. That's also probably the least likely, but I thought I would start off with that just to say that it is possible, it does exist in nature, and we see it happening even in the United States in some limited areas. Other possible solutions to parts of the problem include trying to expand coverage for specific services. So there is a program currently that covers breast and cervical cancer screening and treatment, and it targets low-income people with no health insurance who do not qualify for Medicaid. That could be expanded to other high-priority conditions for undocumented immigrants. For example, you might want to expand it to diabetes. For middle-aged adults, you might want to expand it to colorectal cancer screening. There are some high-value services that you could provide at no cost to people that would have a significant impact on the health of the population. Instead of coverage, you could talk about care, and so the issue of making sure that community clinics have sufficient resources to provide care. It's not a card that you carry around, it's a place where you can go. But the challenge with primary care clinics is they have limited access to specialist care, and that's where the hospital and other sectors come into play. And there really is no resources that community clinics have to buy specialty care or to assure the access to specialty care. So you can diagnose a woman with breast cancer, but then if you need to refer her to a hospital for treatment and there's a 6-month wait, that becomes a huge risk to the person's health. And then finally, there's been a lot of discussion of immigration reform. The bill that passed the Senate included a 10-year bar on use of any services until the applicants actually gain permanent resident status. And so the Senate bill is a little bit like extending DACA to the entire undocumented population, although there is a path to citizenship, so but a 10-year bar basically on any services. Once people have legal status in the United States, however, they could travel to and from Mexico, which they can't when they're undocumented because of the problems of coming back across the border. So there's been some discussion in Mexico about trying to institute binational health insurance so that people who have provisional status under immigration reform could go to Mexico for health care and be able to purchase care there at a reasonable cost. So those are a couple possible solutions to improving access to care for the undocumented. And that's it, and I think we still have 5 minutes for questions and answers. Thank you for listening.
Thank you, Dr. Wallace. For those of you who have questions, you can type it in the chat window, and you see that in the bottom left-hand corner of your screen. But to kick it off, Dr. Wallace, towards the beginning we had a question. Which counties in California have the highest percentage of undocumented immigrants?
So the highest, clearly the county with the largest number is Los Angeles County. We have about a third of the state's total population, and we have over a third of the state's total undocumented. In terms of the proportion of the population that's undocumented, it's probably not Los Angeles. And if I had to throw a dart and guess, it might be like Imperial County, a relatively low population rural county that has a lot of farm workers, but don't quote me on that one. You can quote me on Los Angeles having the highest number, but the proportions are going to vary based on the total population.
We have another question about presumptive eligibility, which might allow an immigrant 2 to 3 months of Medicaid care. Can you touch on that?
For an undocumented immigrant?
Yes, that was the question.
So presumptive eligibility is designed to help a person get into Medicaid. So I don't know enough about the mechanics where if a person, because I think you have to claim, like sign an affidavit saying that you are eligible, and the presumptive eligibility basically takes your word for it. You don't have to provide all the documentation. So my guess is that undocumented immigrants would be hesitant to apply under presumptive eligibility because they would be concerned that they would then be signing some sort of affidavit that would not be true. But once again, so that's my guess. I don't know the details of how it works well enough. But if I was an undocumented immigrant, that would be my assumption.
We had a couple questions about mixed status families. Children in the mixed status families, children who are born here in the States, are they exempt from the ACA tax penalty because they're in a mixed status family?
So the answer is no. If you're born in the U.S., you are subject to both the eligibility and the tax. And then the income that's used to determine your eligibility is only for the people who are eligible. So if you're a child and both your parents are working and you are in a family that makes, say, just above Medicaid eligibility, the parents' income, if they're undocumented, is actually not counted because they're not covered under the mandate. So then the child would be Medicaid eligible. The tax penalty is assessed through the tax system. So once again, the mechanics here is still being worked out. And that's an interesting question. So if the parents don't make enough money to file income taxes, how you would assess a penalty, and that I actually don't know. And I suspect, there's been a number of questions around particularly the undocumented that I've asked policy experts and people who are doing implementation, and the most common answer that I get is we still haven't figured that out yet.
We're running out of time, so I'm going to ask one last question. It was mentioned several times how newly arrived immigrants are generally in better health than their American-born counterparts. About how long does that last? Of course, it's connected to the industries that they work with. But is there any data on how many after how many years do their health conditions start to change?
Yeah, most of the research suggests that it's about 10 to 15 years. So when they first come, the profile is much healthier. After about 10 to 15 years, the profiles converge. But if you look at mortality data, which is generally after people have been here for 20 or 30 years, immigrants actually live longer than their peers born in the U.S. There was a very nice epidemiological article published about 10 years ago that looked at immigrants versus U.S. born, and it looked at separated males and females, and it separated region of origin. So it looked at Asians and Africans and Latin Americans and Europeans, and in every group, the immigrant population had a longer life expectancy than the U.S. born population. So that said, the illness profile converges at about 15 years.
Thank you, Dr. Wallace. Unfortunately, we are running out of time, but I want to thank you for your time. And several of you have been asking whether the slides will be available. And the video of this webinar will be on the UCLA Fielding School website in a few days' time, which you can watch the slides and listen to the lecture. For next, we would like to have you join our next webinar. That's going to be on Wednesday, March 12th. And we will be continuing the conversation with Dr. Linda Delp. She'll be discussing the impact our jobs have on our health in a talk titled Work as a Social Determinant of Health. And if you missed any of our previous webinars, you can again go to the Fielding School of Public Health website. That's ph.ucla.edu, and they are all archived there. Please allow a few days for this one to be posted. Thank you all again for joining, and thank you, Dr. Wallace.
Thank you very much.